and the lens has been implanted, and another 30 seconds remaining. And the vitreous is cleared from the zonular weakness area. And this is what you get at the end. Fairly well-centered IOL and should have a good vision. Thank you so much, and thank you, Saurabh, for this opportunity. I will
Thank
have
you, Love.
to leave
Thanks a
another
lot. Dr. Love is a pediatric ophthalmologist at Calcutta, and he has received his numerous awards at international presentations also. Our next speaker will be Dr. Abhilasha, and I'll ask Dr. Abhilasha to share her screen. Dr. Abhilasha Baharani, she did her DNB from Arvind Eye Hospital, Tirunelveli, and Tamil Nadu. She did her fellowship in uveitis and ocular inflammation from Arvind Eye Hospital, Madurai. She did her fellowship in ocular inflammatory disease from Royal Victoria Eye and Ear Hospital, Dublin, Ireland. She has received a Carl Herbert Award at the Uveitis Society of India in 2012. She got an Award of Distinction and Award of Merit at International Ophthalmology Congress, Innovations and Challenges in Glaucoma and Uveitis in Singapore 2014. She had a Best Poster Podium presentation for Uvea at All India Ophthalmic Society in 2019. She had numerous publications and presentations. She's also written a chapter on ocular tuberculosis in book OCT and OCTA in retinal disorders. Over to you, Abhilasha, for your presentation on cataract surgery in chronic uveitis.
Thank you, Dr. Saurabh, for the kind introduction. I hope my slides are visible.
Yes, ma'am.
Okay, so I thank Dr. Saurabh and AIOS for giving me this opportunity to present my talk on cataract surgery in chronic uveitis. So cataract is the most common surgical indication in uveitis, accounts for 40% loss of vision, comprises 1.2% of all cataract surgeries, but post-op BCVA is 1 to 2 lines worse than in non-uveitic eyes. So in this talk, I'll be talking about the preoperative assessment and preparation, intra-op challenges, and post-op complications and their management. So many a time, this is the picture that we see, and for assessment of the posterior segment, we only get to see the B scan. But apart from vitritis, the choroidal thickness should also be paid attention to because it is a marker of inflammatory activity. Wherever possible, the visual potential should be assessed by looking at the optic nerve function, as well as looking for glaucoma, which can be easily missed when you're busy managing uveitis. The macula should be assessed for the presence of a scar, CME, ERM, or even a full thickness hole, and the patient should be treated or appropriately counseled. The most dreaded complication is hypotony, which can also result in phthisis bulbi. The risk factors are intraocular pressure less than 6 millimeters mercury when the eye is quiescent, seclusion pupillae with a normal IOP, and a poorly controlled inflammation. Ideally, this surgery should be taken up when the eye has been quiescent for 3 months, but generally early cataract is also preferred to assess the posterior segment pathology, and also because advanced cataracts pose greater surgical challenges. The patient needs to be appropriately counseled about the visual prognosis beforehand, and that the surgery takes longer than usual, and the possibility of a delayed visual recovery. It should be insisted upon the patient to comply with the medication even when the surgery has been done, and come for frequent follow-ups. Many of these patients are young, and they should be told that they need reading glasses post-surgery. Preoperative preparation, steroid prophylaxis is required only in those cases where there is risk of macular edema or a recurrence, and oral or local steroids may be preferred. Where there is chance of recurrence of uveitis, like in toxoplasmosis or herpetic uveitis, prophylactic antibiotics should be started 1 week before surgery and to be continued 1 month later. The choice of surgery is, of course, phacoemulsification. Where there is coexisting cataract and glaucoma, cataract should be done first, because anterior segment inflammation because of cataract can result in failure of the glaucoma surgery. Where there is coexistent cataract with retinal problems, a combined surgery can be planned. Anesthesia is surgeon's preference, but I prefer subtenon anesthesia because it is safer and affords more comfort to the patient, and it can be easily given with this curved 23 gauge cannula. Coming to the intro challenges, now I'll be presenting the challenge of a small pupil that we face, and this is 2 eyes of the same patient. So this is the first video. I'm operating on the left eye. In this eye, I had planned for iris hooks. And first, before putting the hooks, the posterior synechiae have to be released. When we are making incision for the iris hooks, the MVR blade should be inserted such that the tip points towards the pupillary margin. This makes the engagement of the iris easy. A long tunnel is not required. The iris hooks are tucked in and the iris is engaged. Here, I'd also like to stress upon the fact that the etiological diagnosis of uveitis should be made. Every attempt should be made to look for an etiological diagnosis and start the patient on appropriate treatment before taking them up for surgery. So as you can see, I'm placing the iris hooks in a diamond configuration. So this is a diamond configuration where the main wound will lie over the iris hook. Now the iris hooks are being tightened sequentially. It's better not to tighten them at once because that can lead to large sphincter tears. So we are tightening, I'm tightening this iris hooks in sequence. Now making the main incision above the plane of the iris hook. Yes. So this way, when we enter with the phaco probe or when we are inserting the IOL, we don't tend to injure the iris. So if you make a square configuration with the iris hook, there is tenting of the iris. And when we are entering with the phaco probe or any instrument, we are likely to damage the iris. Now removing the iris hook is very straightforward. We loosen the clamp and just rotate the hook and remove it. It's also important to clean the viscoelastic thoroughly at the end of surgery. Any residual viscoelastic is likely to contribute to the post-op inflammation. So here I am cleaning the viscoelastic from behind the IOL thoroughly. All the side ports are closed and subconjunctival dexamethasone is given. It's the end of the surgery. Coming to the second eye of the same patient. In this eye, I am proceeding with the subtenon block. I'll enter the subtenon space, the closed scissor. Subtenon block is given with the curved 23 gauge cannula. In this case, I have planned a B-hex ring. So posterior synechiae are being released from both sides. Now B-hex, before implanting the B-hex ring, we have to do a stretch pupilloplasty. Viscoelastic has to be injected even under the iris to provide room for the B-hex ring. Now this is the ring. It is a non-elastic ring. It has got 6 flanges with dots and without dots and flexible notches. So you engage the B-hex ring there, and a 23 gauge forceps has to be used for doing this. Removing is also straightforward. It comes out easily. B-hex ring provides more room for surgery compared to iris hooks. And again, cleaning the viscoelastic from behind the IOL. And that's the end of the surgery. Coming to the comparison between iris hooks and B-hex ring. So these are 2 eyes of the same patient. So pupil size that is almost the same between the two, but the B-hex ring provides a better circumference, so rhexis becomes easier. The learning curve is slightly steeper in B-hex ring, but if you use the recommended 23 gauge forceps, it's easy. Surgical maneuvers are also easy in my experience with B-hex ring. because the iris is not tented and there is more space for you to work. Surgical time is also less for BHEX ring. Post-op distortion of pupil is also lesser with BHEX ring. However, the post-op astigmatism was equal in these two cases because of extra side ports for the iris hooks. It did not affect the post-op astigmatism. Post-op complications, aggressive post-op steroid should be given. I prefer a difluprednate with NSAIDs to prevent posterior synechiae and pupillary membranes. The pupil has to be kept mobile by using home atropine BD. So the principle is to over-treat and relax and not under-treat and then try to catch up with the inflammation. Posterior capsular opacification and phimosis is common. You can get this kind of cocooning of the IOL. To prevent this, a circular large rhexis should be done. Acrylic IOL with square-edge design is preferred. Meticulous removal of viscoelastic like I showed in the video, and there should be good control of post-op